Hi, now we will read about empyema. An empyema is an accumulation of thick, purulent fluid within the pleural space, often with fibrin development and a loculated, that is, walled off area where infection is located. Most empyemas occur as complications of bacterial pneumonia or lung abscess. Other causes include penetrating chest trauma, hematogenous infection of the pleural space, non-bacterial infections, or iatrogenic causes, that is after thoracic surgery or thoracentesis. Pathophysiology. At first, the pleural fluid is thin with a low leukocyte count, but it frequently progresses to a fibrinopurulent stage and finally to a stage where it encloses the lung within a thick exudate membrane, that is loculated empyema. Clinical manifestations. With an empyema, the patient is actually ill and has signs and symptoms similar to those of an acute respiratory infection or pneumonia: fever, night sweats, pleural pain, cough, dyspnea, anorexia, weight loss. If the patient is immunocompromised, the symptoms may be more vague. If the patient has received antimicrobial therapy, the clinical manifestations may be less obvious. Assessment and diagnostic findings. Chest auscultation demonstrates decreased or absent breath sounds over the affected area, and there is dullness on chest percussion as well as decreased thermometers. The diagnosis is established by a chest X-ray or chest CT scan. Usually, a diagnostic thoracentesis is performed, often under ultrasound guidance. Medical management. The objectives of treatment are to drain the pleural cavity and to achieve full expansion of the lung. The fluid is drained and appropriate antibiotics in large doses are prescribed based on the causative organism. Sterilization of the empyema cavity requires 4 to 6 weeks of antibiotics. Drainage of the pleural fluid depends on the stage of the disease and is accomplished by one of the following methods. First one is needle aspiration, thoracentesis. With a thin percutaneous catheter, if the volume is small and the fluid is not purulent or thick. Second one is tube thoracostomy, chest drainage using a large diameter intercostal tube attached to water-steel drainage with fibrinolytic agents instilled through the chest tube in patients with loculated or complicated pleural effusions. Open chest drainage, the third one, via thoracotomy, including potential ribs resection to remove the thickened pleura, pus and debris and to remove the underlying diseased pulmonary tissue. With long-standing inflammation, an exudate can form over the lung, trapping it and interfering with its normal expansion. This exudate must be removed surgically. Decortication. The drainage tube is left in place until the pus-filled space is obliterated completely. The complete obliteration of the pleural space is monitored by serial chest X-rays, and the patient should be informed that treatment may be long-term. Patients are frequently discharged from the hospital with the chest tube in place with instructions to monitor fluid drainage at home. Nursing management. Resolution of empyema is a prolonged process. The nurse helps the patient cope with the condition and instruct the patient in lung expanding breathing exercises to restore normal respiratory function. The nurse also provides care specific to the method of drainage of the pleural fluid. Example, needle aspiration, closed chest drainage or rib resection and drainage. When a patient is discharged to home with a drainage tube or system in place, the nurse instructs the patient and family on care of the drainage system and drain site, measurement and observation of drainage, signs and symptoms of infection, and how and when to contact the healthcare provider. Thank you.